I took a lot of the context kind of slides out of it. So if you do have some confusion on some of the stuff on the slides, don't hesitate to look back at the lecture slide because I provided that context into why this is occurring. So, but for studying purposes, if you kind of already understand the context and you just want to know what the important information is, this slide presentation is helppful for that. All right, so we had 6 lectures. The first one we did was just a review of normal anatomy and physiology. We talked about the pericardium, how it's a 2-layer sac that basically serves to keep the heart contained in its location so it's not freely swinging around like a pendulum. It prevents that extreme dilation, so it supports function of the heart, and then it also serves as a barrier from infection, so it protects the heart from infection. We talked about the 3 layers of the heart. We have the epicardium, which is the same as the visceral layer of the pericardium. We talked about the myocardium, which is the muscular layer. That's the functional layer. And we talked about the endocardium, which serves, it's the innermost layer, but it serves as kind of that barrier, so you don't have direct contact of the blood inside of the chambers of the heart with the myocardium. And then we talked about how with the myocardium itself, you have the contractile portion of it, which is the muscular part, which gives you that function. But it does have an additional layer where it's the non-contractile stuff. So the stuff for the conduction system, the things that regulate the function of the muscle, and also the supporting stuff like the blood vessels and such to provide the nutrients and the oxygen that is needed for the muscles to actually do their work. When we talk about actually like things that impact the function of the heart is receiving all these inputs from so many different things, organs, and the nervous system and all that kind of stuff to kind of regulate its function. There's a number of ways that this happens. The first one is the Bainbridge reflex, which responds to atrial stretch. So in conditions where you're having increased venous return, you're increasing kind of that preload coming back to the atria, the heart's going to detect that atrial stretch. It's going to realize, hey, I need to work harder and get rid of this volume before it starts to affect my function. And so the Bainbridge reflex will increase that heart rate as that venous return increases. The other thing is the thoracic pressure. So as you inhale, you create that negative pressure environment that increases that preload, so that increases that venous return to the heart. And then when you exhale, you create that positive intrathoracic pressure, and it decreases that venous return. So having somebody breathe normally can impact the function of the heart. And then, of course, the main one that has a little higher level input is the autonomic nervous system, which is comprised of the sympathetic and the parasympathetic nervous system. Sympathetic, our fight or flight response, it synapses on the SA node, the atria, the AV node, and the ventricle, so all 4 areas. And basically, it will increase heart rate, it will increase your conductivity, so how fast that action potential goes from point A to point B. It will increase that speed. And then it also increases the contractility, so how strong the atria will squeeze and how strong the ventricle squeezes. The parasympathetic nervous system, on the other hand, which comes from the vagus nerve, it is your rest and digest component, right? And its synapse is actually only on the 3 areas. It does not synapse on the ventricle. So what ends up happening with this is you decrease your heart rate, you decrease that contractility of the atria, and you decrease that conduction from the SA node down to the AV node, and then also through the AV node itself. So it kind of slows the heart rate down, and it slows the heart rate down using the parasympathetic nervous system. Again, I don't expect you to label, what phases and stuff like that things happen. But what I do expect you to know about the action potentials are, if you have cardiac muscle, what ions, what electrolytes are required is sodium, calcium, and potassium. So at the level of the cardiac muscle, you need all three of those things. When you compare that to the pacemaker cells or the conduction pathways, you really only need two. You just need calcium and potassium. Sodium doesn't play a significant role in the depolarization and repolarization of the pacemaker cells. So this makes it different, this makes it unique compared to cardiac muscle. And then we also talked about how calcium, in addition to being important for the depolarization of pacemaker cells, calcium is also vitally important for the actual function of the myocyte itself. So you need this calcium in order to get the muscle to contract.
Hey, just stop for a second. You guys should all be tracking that the government shutdown happened last night, right? If you're not tracking, you should probably read the news a little more.
All right. So we'll continue the mission regardless of what's happening outside these walls. So calcium is important for the actual muscle to contract, okay? So you have to have calcium in order to get the functional component of the muscle. And the way that works, if you remember, and these are some slides I took out, is calcium is required to help with that kind of that binding and that power flex component to it. So from anatomy standpoint, from the gross anatomy standpoint, understand the flow of deoxygenated blood through the heart chambers and stuff. What structures receive that deoxygenated blood? What structures does it have to go through in order to get to the ventricle and then up to the lungs and then become oxygenated and then kind of come around back down to the left side and get out into the aortic systemic arterial system. Know at what phase are the different valves open and what phase are they closed. So like tricuspid valve is open during diastole, and you get that flow of blood from the atria and into the ventricle. The ventricle will then close the tricuspid valve with the initial squeeze. The pulmonic valve will open during systole, and then that blood will get ejected out of the right ventricle and into the pulmonary artery. And then that blood becomes oxygenated, comes back to the left atria. During diastole, will go through the mitral valve and then into the left ventricle, which then will close the mitral valve as that ventricle starts to squeeze, and then it will open the aortic valve, and then that oxygenated blood will leave the heart and then go and start perfusing and providing oxygen and nutrients to all the vital organs. And then just knowing the valve leaflets, so the atrioventricular valves, your tricuspid and your mitral valve, they're open during diastole, and they close at the beginning and the onset of systole, which corresponds to the S1 that you hear in auscultation. Know that there is a difference in the mitral valve, where it's the only valve that has 2 leaflets. All the other 3 valves have 3 leaflets. When we look at the semilunar valve, so this is your pulmonic and your aortic, these are open during systole, they close during diastole, and their closure corresponds to your S2 or your dub on auscultation. And then also recall that the opening or the osteas for the coronary arteries come off of just above that aortic valve, so that's where that blood flow to the coronary arteries come from. And then recall that the papillary muscles are important too. They attach to your tricuspid and your mitral valve, and they're there to kind of give that counter resistance to keep that leaflet of those valves closed, so you maintain that one directional flow of blood out of the heart instead of it backing up into the atria, which can lead to a number of different pathologies. And then from a coronary artery standpoint, unlike other arteries, perfusion primarily occurs during diastole. And this is important because One, the aortic valve, when it's open during systole, kind of blocks the flow of blood into those osteas and into the arteries. But two, it's important because during systole, you're getting that squeeze of the ventricular muscle, the myocardium, and blood flow through tiny vessels trying to penetrate into the myocardium would be squeezed and you would get no flow. So the heart's designed for that situation where that perfusion is going to primarily occur at the time when the muscle is relaxing. Otherwise, you wouldn't get perfusion of the myocardium. Then just know kind of a general characteristic of some of the coronary arteries, what major structures do they perfuse, because that will help you in the future when we talk about acute coronary syndromes and heart attacks, where if you have an occlusion of one of those coronary arteries, you can kind of understand what are the secondary impacts, what structures are going to be damaged because of that lack of perfusion. So left anterior descending, bulk of your left ventricle, you're including your bundle branches. This is also known as like the widowmaker artery, because if you take this out, then a large portion of your left ventricle is going to get knocked out and you're going to lose the function of the left ventricle. The circumflex artery, understand that the lateral part of the posterior wall is going to be impacted. You may have the SA node in about 25% of individuals, where the circumflex artery provides the perfusion to the SA node. The right coronary artery, yes, the inferior wall, that's great. Right ventricle, yep. But kind of big things are going to be your conduction systems are going to be knocked out if you have an occlusion of the right coronary artery. And then just understanding that the posterior part of the heart, this is kind of a concomitant of both the right coronary and the circumflex artery kind of perfusing this. So if you have an occlusion of either one of those, it could affect the function of the posterior wall. And then we talked about how the actual measurement of work of the heart is cardiac output, which we calculate by calculating the stroke volume and multiplying that by your heart rate. But we said that sometimes that's difficult to actually measure the exact cardiac output, so we have a different physiologic measurement that we do called ejection fraction. But if we really wanted to know what the actual work function of the heart is, we need to calculate the cardiac output. And when we talk about what goes into calculating your cardiac output, that stroke volume is made up of three main components. So your preload and your contractility, which have a positive impact on your stroke volume. So the higher that is, you tend to have a larger stroke volume. The afterload, on the other hand, has an inverse relationship where the higher your afterload, the less your stroke volume is going to be. When we talk about the preload component of your stroke volume, this is basically can be measured as either the end diastolic volume or your end diastolic pressure. So this is the amount of volume in the ventricle at the end of diastole immediately before systole starts. And there's lots of things that kind of go into factoring in what makes up your preload. So how much blood is coming back to the heart in the first place. That's going to be important because you need that volume to actually be in the heart, ready to actually get into the ventricle. Your atrial contraction, because about 25% of your end diastolic volume in the ventricle comes from that atrial contraction. So if you have a condition such as atrial fib, where you lose that atrial contraction, then you're losing about 25% of your volume. What's the resistance of the valves to open and allow that flow of blood from one chamber to another? What's the ventricular compliance? So how willing is that ventricle to stretch to accommodate that volume actually coming into the ventricle in the first place? And then the heart rate component of preload is not how many beats per minute. It's more, if you have a fast heart rate, you decrease your diastolic filling time, so that's going to decrease the amount of time you can get volume from the atria into the ventricle. So you really want kind of a slower heart rate to allow more time for volume to get from the atria and into the ventricle. The second component of stroke volume was myocardial contractility, so how strong is that contraction? In addition to like the autonomic nervous system impacting this, there are medications that we can give that will impact the contractility. There's things that will positively impact it, so make the squeeze stronger. But there are other medications that actually could make the squeeze not as strong, make it weaker. And that's important to know, because what if I'm prescribing somebody something for malaria prophylaxis and they happen to have heart failure? Is that a medication I'm going to want to give them, right? So it may change how you manage these patients. Then we talked about the final factor in the stroke volume, which is afterload. That Laplace law equation seems complicated. I'm not going to give you that to calculate stuff, so please don't memorize this. But basically think of your afterload is your blood pressure. Clinically, we can simplify this equation down to blood pressure, okay? And basically afterload is what is the resistance, what is the pressure that the heart has to overcome in order to open the aortic valve, open the pulmonic valve, and get that blood to flow out of your ventricle, okay? So the higher your afterload, the more pressure the heart has to generate to get that blood flowing out of it, okay? So things that could impact your afterload, your systemic vascular resistance. So what are the blood vessels doing? Are they constricted or are they dilated? You don't want an excessive amount of dilation because you're not going to get the flow then, right? But you also don't want an excessive amount of vasoconstriction because that's going to interfere with the flow. What's the aortic pressure and the pulmonic pressure? So what exactly is that pressure that has to be overcome in order to open those valves? And then is there disease affecting the valves? So the valves themselves have their own resistance to actually opening. So that was the factors required to calculate cardiac output. In order to do a less invasive kind of measurement of function and work of the heart, we've come up with the ejection fraction, which is just the percentage of blood that is pumped out of the heart or out of the left ventricle after every heartbeat. 100% is not the normal. The ejection fraction range for normal is about 55 to 75% of blood is ejected with systole. And the way that you calculate this is the stroke volume divided by the end diastolic volume. I will potentially give you some values, and you're going to have to calculate what the EF is or what the cardiac output is. But I will give you values to do that. It is simple math, so if you have a calculator, great, use it if you don't trust yourself. But if you don't have a calculator, it will be simple enough as long as you know some multiplication and some division techniques. So.
Oh, no.
Yeah, so continuing on, so EF, the reason, even though the EF, the gold standard, is to do that catheterization, we don't have to actually do an invasive test to calculate the EF. An ultrasound, which is the most common way that we will calculate the EF using the echocardiogram, that is a non-invasive way and approach that we can calculate the ejection fraction for a patient. And then just for helping you to kind of maintain kind of the correlation between cardiac output and ejection fraction, don't think that ejection fraction equals your stroke volume. It doesn't. Ejection fraction is your stroke volume divided by your end diastolic volume. Your stroke volume, another way to kind of simplify this, is your stroke volume is your end diastolic volume minus your end systolic volume. So if I'm going to try to calculate my ejection fraction, then it's the product of end diastolic minus the end systolic, that value then divided by the end diastolic volume. So basically this is kind of, think of it as we're calculating that percentage. Okay. And then we talked about this is just kind of a visual representation of how the three factors of stroke volume impact your stroke volume and your cardiac output. So this is your baseline. If I increase my preload, I'm going to add all this extra work because now I have an extra volume to actually be able to flow out of the heart. If I increase my contractility, I increase my work because I'm going to be able to have a higher ejection fraction, basically. So if I normally only have 65%, but now I increase my contractility, now I'm having 75% that is leaving the heart with each heartbeat. Now I'm having additional work occurring there. And then when I increase my afterload, I'm actually decreasing my work. I'm losing all of this because I have to maintain a higher pressure, or I have to generate a higher pressure in order to open the aortic valve, and then I have to maintain that pressure, that higher pressure for a period of time before the valve will close. So what ends up happening is you get a premature closure of the aortic valve. The flow out of the ventricle stops, and then you lose all that work. We did talk about how there is a caveat, though, for preload, and increase in preload, meaning increased stroke volume. And that's the Frank-Starling mechanism, where up until a point, as you increase that preload, it will increase your work. But then you actually start to then get a downslope or loss of work if you've gone too far. Okay? And that's because really at the microscopic level, you start to lose those actin-myosin interactions, and so you just get a weaker, work effort. And then we talked about how contractility impacts the squeeze, or how things can increase the contractility or the squeeze. But again, that kind of gets to a point before you start to lose function. So it's to a point. So that was our first lecture. Then we went on to talk about cardiovascular exam and heart sounds. We talked about the tenets of inspection, palpation, and auscultation for any kind of physical exam, which is no different from the cardiac exam. We talked about the inspection part. First thing you're going to do is look at the configuration of the chest, because any kind of deviation from a normal configuration could impact function of the heart. So we talked about how, pectus excavatum, where you get this sternum getting depressed in, how that could distort the normal anatomy and affect the lung placements and lung expansion and all that. It can also affect the outflow and the inflow of blood to the heart, to and from the heart. So that can have a negative consequence. We talked about pectus carinatum, where now that sternum is actually anteriorly displaced, how now you have a wider chest, and that can impact the normal expansion of the lungs, and that can limit the function of the heart. We talked about COPD, which causes like a barrel chest, where now that AP diameter is different than normal, and you basically have like an excessive aeration of the lungs, and that can impact the function of the heart. And then we talked about like scoliosis, where that can affect the lungs, and that can also affect and distort the outflow and inflow of the heart, and that can impact the function. Next on inspection, we talked about just looking at the skin and being able to tell like what's going on with like in regards to like cyanosis. And we talked about how peripheral cyanosis, so things that affect the digits of the extremities. Typically, we think of this as being a blood flow problem. It's not an oxygenation problem. It's a blood flow problem to that region. And there's a number of things that can impact that perfusion or that blood flow to that region. It could be medications, it could be clots, or it could be like they're in shock and they just are not circulating blood properly. Then we talk about central cyanosis, which is a problem with oxygenation, which we talked about that with like our congenital heart diseases, where now it's just the percentage of hemoglobin that is oxygenated is down for some reason. And now it's just the blood that is circulating just doesn't have enough oxygen in to meet the demand. Then we talked about looking at things looking for like anemia, where you're going to have like this pallor. Blood is circulating, or at least maybe not hemoglobin is circulating, or not enough hemoglobin is circulating, but there is perfusion occurring, but you just don't have enough of it, and that can lead to developing a pallor, especially like in things like the conjunctiva, which is one of the more common areas we look and assess for anemia. Then we looked also, or talked about looking at the extremities, looking for edema, which can give you an idea of the function of the heart. If the heart is failing, then fluid's going to accumulate in spaces, and you may get pitting edema, which you can see in this picture, where you just press on it, it stays there. You can see the fingerprint on that area, and that's usually a sign that we see with heart failure. Then we talked about clubbing and how this is a chronic problem. This is not something that just acutely develops. It's a chronic problem. Then we talked about jugular venous pulsations, and we talked about how this jugular venous pulsation and the wave forms that we can see with it gives you an idea of what's going on in the right atria as far as how the pressure is in the right atria. So there's a direct link from the right atria to the jugular veins, so we can see what's going on with the pressure in there. We can kind of get an idea of the different pathologies based on the differences in abnormalities that we see on that pulsation wave. Now, don't confuse jugular venous pulsations with jugular venous distension. Jugular venous distension is a pathologic finding where now that pressure is too high, and now you're having that backup of fluid into the jugular vein. And we also talked about how you have the jugular venous pulsation waves and the waveforms. We talked about how the A wave is the atrial kick, where the tricuspid valve is open, so you're getting that active flow of blood out of the atria and into the ventricle. Right at just after that peak, you're going to get a closure of the tricuspid valve, which is going to start your systole. As the ventricle starts to squeeze, you're going to have a little cessation of the drop of that A wave, and that's just from the tricuspid valve kind of billowing back into the atria, but it's just a very brief kind of pause, and then that pressure continues to drop into your X descent, which is a period of time where you have the atrial is relaxing, it starts to fill, but the tricuspid valve is closed because we're in systole, right? We're between S1 and S2, so we're in systole. This is when you're just starting to have that filling, that passive filling of the atria with that venous return coming back. Then as we start to fill the atria more and more and more, that tricuspid valve is closed, that pressure starts to increase up into the V wave. At this point, you get a closure of the aortic and the pulmonic valve, and so you now have officially started the diastole phase of this, but that tricuspid valve is still closed. And that pressure is going to increase because you're getting all that venous return and it's not going anywhere. And then all of a sudden, the tricuspid valve opens right after that V wave, right after that peak, and now you get that sudden drop of pressure in the right atria. And then that brings you into the Y descent, where atria is dumping into the ventricle, and then you start to kind of get that venous return coming in, the ventricle is filling up, and so that pressure starts to rise a little bit, and then that starts to cycle all over again, where now you get that atrial kick or that atrial squeeze, and that pressure suddenly goes up again. So just knowing kind of what's going on in the different phases of the pulsation wave. Some differences or abnormalities that you may additionally appreciate with the jugular venous pulsation waves is something like Kussmaul's sign, where when the person takes a breath in, you should see a drop of that jugular venous pulsation wave. However, if there is a problem with the ventricle where it doesn't want to accommodate all this additional volume coming to it, you will actually see on inspiration that wave goes up. So Kussmaul's sign, you see that jugular venous pulsation wave go up with inspiration. The hepatojugular reflex is typically something you see in volume overload states where somebody presses on the right upper quadrant and that jugular venous pulsation wave goes up because you're pushing all that extra volume out of the abdomen and up towards the heart, but the heart itself cannot accommodate all that extra volume, so it backs up into the jugular veins instead. Then we talked about PMI and how we can kind of determine where that point of maximal impulse. Normally it should be in the 4th or 5th intercostal space in the mid-clavicular line. That's where you normally should see it. If you have any kind of distortion with this, it could indicate something like a enlargement of the left ventricle. So if it's distorted to the left, then you think of like a left ventricular hypertrophy. If you have a hyperdynamic pulse, then it could be indicative of a volume overload. Typically, you're also going to hear a S3 in those situations. If you have a pressure overload, then basically that impulse is just going to last longer because it's having to squeeze a longer period of time to get flow of blood out of the ventricle. And typically on auscultation, you're also going to have an S4 associated with that finding. Precordium thrills, so this is like a low frequency vibration that you can hear. Typically we see this in systolic murmurs that are rated as 4 to 6, so loud murmurs. Typically you can palpate this low frequency vibration. We'd also talk about pulse pressure differentiation. So the pulse pressure is really what's the difference of your systolic minus your diastolic pressure. Normally it should be, like anywhere from like 20 to 30, or 20 to 30, but if it's more than 40, then that is an increased pulse pressure, which could indicate different pathologies. If you have a narrowed pulse pressure, then that could be indicative of like a hypovolemic kind of state. So like situations like dehydration could lead to that. So pulse pressure can tell you, give you an idea of what's going on. And the other thing from a pulse palpation is you should have symmetric pulses right to left and upper extremity to lower extremity. There shouldn't be a difference between those regions, okay? Then we talked about auscultation as the kind of the last part of your physical exam. We talked about how there are the normal heart sounds, but then there's abnormal heart sounds and there are murmurs. And those typically represent some kind of pathology. We talked about how when you go to listen to somebody, you gotta use both the diaphragm and the bell of the stethoscope. And the reason for that is those two parts detect different things. We talked about how the diaphragm actually detects high-pitched frequency sounds, and the bell detects low-pitched frequency sounds, okay? And then we talked about if you hear an abnormality, the 3 questions you have to ask to help you determine what the pathology is where's my stethoscope on the auscultation sites? Am I using the diaphragm or am I using the bell to best hear this abnormal sound? And then is this occurring during systole or is this occurring during diastole? Then we talked about the normal heart sound. So S1 represents the closure of the mitral and the tricuspid valve. It is a high-pitched frequency, and this represents the onset of systole. We talked about S2, or the dub, which is the onset of diastole, and this is also high-pitched, and it represents the closure of the aortic and the pulmonic valve. We also did talk about how there is this normal physiologic splitting of the S2, which represents basically the inspiration, the difference in closure of inspiration versus expiration. With inspiration, because you're having all that extra volume coming back to the right side of the heart, you keep that pulmonic valve open longer, but then also you hold on to extra volume in the lungs, in the vasculature of the lungs, so you get a premature closure of the aortic valve, so you see the A2 actually move to the left. So what you're getting is a even further splitting of the S2. And that's a normal thing. But then when you exhale and you create that positive pressure environment, you start to see those things come back to potentially be a fused S2. Then we went on to talk about abnormal heart sounds. So S3 typically is abnormal, where this is a early diastole heart sound, just occurs after the S2. It is a low frequency thing, so this is something you want to use the bell of your stethoscope to hear. And typically we associate this condition with a volume overload state. So this would be like your heart failure patients. You're going to hear an S3. This is also known as like a ventricular gallop. Then we talk about S4, and we talk about how this is a late diastole sound immediately before the S1. This is also a low pitch, so best heard the bell, and it's known as the atrial gallop. And the reason you hear this is when you have a non-compliant or stiff ventricle, because with the atrial kick, you get that sudden flow of blood into the ventricle, but it's just running into a brick wall, a non-compliant ventricle, and you're hearing that blood hitting that wall. And then this is just kind of a compare S3 to S4 and why we hear it. Then we went on and we talked about how ejection sounds, think of these as extra systolic sounds, where these are high-pitched frequency sounds, so diaphragm of the stethoscope. If you hear an early systole, typically think of these as being like your stenotic valves and like your aorta and your pulmonic valves. If you hear a mid-systolic ejection click, then we're thinking of things like mitral valve prolapse as the cause of this type of sound. Am I going to give you an audio file to hear and tell me this? No. I'm going to describe it using words. You hear a mid-systolic ejection murmur. You hear a early systolic. So just know kind of which those correlate to. Opening snaps, on the other hand, compared to ejection sounds, is a diastolic sound, also high-pitched, but these are typically associated with conditions like mitral stenosis, where the mitral valve should be opening, but there's a resistance to that opening, so you kind of hear this sudden snap as the pressure builds higher and higher. It's kind of forced open. And then this is just kind of a chart to kind of compare all of those extra heart sounds. Then we went on to talk about murmurs. And the three reasons you might hear a murmur is you have blood flow going across, an abnormal amount of blood going across a normal heart structure. So we talked about situations like in ASD and our congenital heart disease. The things that you hear typically are due to an abnormal flow of blood across a normal cardiac structure. You could hear normal blood flow across an abnormal cardiac structure, so an abnormal heart valve, or you're hearing abnormal shunting of blood. So this would be like your ventricular septal defect, where you have blood flowing from the left ventricle into the right ventricle. So that would be an abnormal shunting present. And then there's some other descriptors that we can use to describe murmurs. So we talked about how you can describe the timing of it, and it's basically, it involves when is it happening. Systole, diastole, is it happening for the full duration of systole, so holosystolic, or is it a continuous thing where it's happening both diastole and in systole? Then we also talked about how you can actually get a good idea of what murmur you're hearing simply by having your stethoscope in the different auscultation sites and then knowing, is this a systolic or a diastolic murmur? And this is important because if I am listening in either the aortic or the pulmonic area, you don't have diastolic murmurs, you only have systolic murmurs. And those valves, the aortic and the pulmonic, they should be open during systole. So that means that I have stenosis murmurs in those areas. So I have an aortic stenosis if I'm listening in the right upper sternal border. I have pulmonic stenosis if I'm listening to the left upper sternal border. Okay. When I go down to the tricuspid area, I have both systolic and diastolic murmurs. If it's a holosystolic murmur, then I'm thinking that this is a tricuspid regurgitation. If I have a diastolic murmur when that valve should be open, then I'm thinking of a tricuspid stenosis. When I'm listening to the mitral area, a holosystolic murmur is going to be mitral regurgitation because the mitral valve should be closed during systole, right? So that's a regurgitation murmur. If I have a diastolic murmur, then that's a mitral stenosis murmur. And then going back up to the left sternal border or Erb's point, those are where you're going to hear the diastolic murmurs of your aortic and pulmonic things. So that's where you're going to have your aortic regurg and your pulmonic regurg murmurs best heard at Erb's point or at the left sternal border. And then just know that the grading for this different murmurs are different. So systolic goes from grade 1 to 6, and diastolics go from 1 to 4. So you can't say that this is a grade 5 diastolic murmur. Don't say that this is a very quiet murmur and say, oh, this is a 4 or a 5. Saying that grade actually is indicating a specific meaning to it. So people coming after you would be able to understand what you heard and compare. Then we talk about pitch, and that's just high versus low. Quality is what does it sound like? Is it harsh? Is it blowing? Is it rumbling? And then the configuration of the shape is basically over time, how does that intensity change? So with a crescendo, that intensity goes up. The decrescendo, it goes down. Or does that murmur stay the same intensity throughout? So what does that change over time? And then we also talked about how you can do some dynamic maneuvers to help you determine different murmurs. And basically when we're doing dynamic maneuvers, we're just simply affecting the preload and the afterload. So we're just changing those things, and we're just seeing how changing those variables affect the murmur that you hear. And this is kind of a good chart to kind of see what you would expect to happen as you do a dynamic maneuver. Okay. We'll start this up and then we'll take a break. So our third lecture was just doing diagnostic studies and procedures for cardiovascular system. And there were so many out there that we talked about. We talked about how your chest X-ray can give you a lot of good ideas of like the external anatomy and also help you rule out some things. But really, when we talk about imaging, as far as being really beneficial to our study, the CT scan really provides us some good information. Okay, because now I'm actually looking at the anatomical features better, particularly things like what's the great vessels doing, what's the pericardium doing, what are the coronary arteries doing. I can also diagnose a couple of other different things. So there's lots of advantages to be doing a CT scan. And I usually get some pretty good anatomy visualization, especially like coronary artery anatomy visualization. But there are limitations to this. So I need contrast dye in order to do this. So if I have somebody who is allergic to iodine, or have somebody who has like renal failure, that could impact the kidney function even worse. The other downside to a CT is it does not give me an ejection fraction, so it doesn't give me a functional assessment. Cardiac MRI, much more expensive to do, takes a long time to do it, but it does help in a diagnosis of lots of different kind of medical or cardiac conditions. And a lot of these can be done without contrast. So I may not need to do any kind of contrast in order to make these assessments. One of the key things that we can use this for is if we aren't sure if an area of myocardium is dead or if it's just hibernating, I can do this study and it can tell me if this is hibernating myocardium or is this dead or infarcted myocardium. Let's go ahead and take 10 minutes, come back at 11, and we'll finish out. There's always a risk of having a reaction to the sedation, but it also could involve perforating the GI tract. And you are placing a semi-rigid scope into the esophagus, so you could always punch a hole through the esophagus. And then if you're doing a transthoracic echo, if you have a larger patient, the body habitus may interfere with getting clear pictures or even being able to visualize the structure that you would like to. So this is just kind of an indicator, shows you what the different versions are. So transthoracic, just probe directly on the chest. Low risk, doesn't require any kind of medication, sedation, can easily be done bedside or in the clinic. Whereas the transesophageal echo, much more invasive, does require sedation and does require specific environments in order to do this because you have to monitor the patient during their sedation and all that. There's lots of different reasons that we would do an echocardiogram, but it kind of comes down to it gives us a great assessment of the internal anatomy of the heart. Then we talk about nuclear medicine studies, which shows you the actual perfusion of blood into the myocardium itself, using like a radionucleotide to do this, so I can see if blood is actually getting into the different regions of the myocardium. But then we talked about, and then finished up with talking about EKG studies. So we have like the EKG, which is just a 10-second snippet of time, but that can be very difficult to catch arrhythmias that come and go. So we have methods of doing a longer continuous monitoring of EKG using like your Holter monitor, which is only good for 24 to 48 hours max. But your Zio patch gives us a much longer duration to try to catch some of those intermittent arrhythmias. These work better by having maybe a higher yield than just a 10-second EKG to catch those arrhythmias. But then we talked about how all of those studies that we just talked about are all done at rest, where a lot of cardiac pathology occurs during exertion, right? So we have to have some way of testing the heart during stress or during exercise. So we've come up with the stress test versions of all of those things. So we have the exercise treadmill stress test, which is a evaluation of the conduction system doing an EKG while the person's running, like on the treadmill here that you see. And now I can check to see, is there any kind of ischemic changes that occur with exertion on the EKG. Then we talked about how you can do a stress echo, where now I'm looking at the functional change with an exertion like exercise or a chemical stress using like dobutamine in order to kind of speed up that heart rate. And I can see if there's a functional change with that stress. And then we talked about how with nuclear medicine I can do a stress test, and now I can compare the perfusion of the myocardium at rest to what it is during exertion or during that stress. And now I can see if there is this perfusion deficit with activity and see if I need to do further procedures in order to address that perfusion problem. Then we talked about laboratory tests, and we talked about how there's lots of different ones that you can order, but really this is your list of tests that you would see in primary care or see in the ER, and that will help you with your diagnosis. And these are the tests that we'll be talking about over the course of this curriculum. Then we went on and we started talking about invasive testing, and the first one we talked about was catheterization. We talked about how this could be a left or a right, and there's a reason you would do a left over a right. or vice versa, depending on what you are trying to evaluate. We talked about a left heart cath. To get access to the left side of the heart, we need to go through an artery. So think of this as a much more invasive test, bleeding risks and all those types of things. But the advantage of a left heart cath is it can be both diagnostic and it can be therapeutic. So lots of things that I can assess from a diagnostic standpoint with a left heart cath, to include defining the coronary artery anatomy, evaluating, like they come in with acute coronary syndrome, like a heart attack or whatever. I can assess it, see what's going on with that. I can also assess function of the left ventricle. I'm already there on the left side, right? So I can assess that. But then from a therapeutic standpoint, I can do procedures to fix problems. So if there's a coronary artery perfusion deficit, I can do procedures to open up that perfusion, open up that coronary artery again, so I can restore blood flow to the myocardium. Then we talk about right heart cath, and to get access to the right side, we need to go through a vein. And typically we think of right heart catheterization as a monitoring kind of procedure. So it allows us to monitor different variables in order to take care of our patients, especially critically ill patients. And there's lots of things from a diagnostic monitoring thing that we can get with a right heart cath. Regardless of left or right, and the reason that these are invasive tests is there could be all kinds of reactions or complications from doing this. So this is not, we don't just do this willy-nilly. There's a reason that we would want to do this test. So things that we need to be careful of. Yes, you got the allergic reactions to the contrast dyes that we got to do, but I am potentially threading wires into damaged structures. I can then lead to further complicating that structure, perforating it, bleeding out, cause other problems. I can break things off, cause strokes, and those types of things. So this is a high-risk procedure. Then the other invasive study that we talked about was an electrophysiology study, which this is running a bunch of catheters into the right side of the heart, where now I am kind of assessing the conductive system, especially if there's like these arrhythmias, especially like recurrent kind of arrhythmias, where I'm trying to find out where this short circuit is occurring in that conduction system, and then potentially if I can identify where that is, I can then also therapeutically fix it, get rid of it, so now those folks do not have those kinds of arrhythmias anymore, because I have now gotten rid of that short circuit. Then we moved on and started talking about infective endocarditis, and we talked about how this condition can develop anywhere that there is endocardium. And this could be including like the surfaces of the valves, it could be surfaces in the lining of the chambers of the heart, or even things like your papillary muscles. And the problem is, in this condition, is you get this infection that produces this very complex vegetation, and that starts to interfere with the normal functioning of that structure. And there's a couple of ways to kind of describe an infective endocarditis, to include like what kind of bacteria it is, what the clinical course was it rapid, was it subacute or not, but so the different ways that we can describe this based on what we're seeing. We talked about how community-acquired infective endocarditis typically is going to affect the mitral valve. And because this is a community-acquired thing, it usually is a less invasive kind of bacteria, so we're thinking like a strep species for this. When we talk about healthcare-associated infective endocarditis, we're thinking of things that are more invasive, so like staph-type species, MRSA, those kinds of things. And then we talked about IV drug users, and we talked about how in IV drug users, the most common structure affected by this is actually the tricuspid valve. It's a right-sided disease as opposed to a left side in the other version of this. And there's lots of things that kind of put somebody at risk of developing this. So do they have an anatomical structure abnormality to like the heart valves, or do they have like a foreign body in the heart, like your prosthetic valves? Being elderly and being male, basically you're causing damage to those valves, and that can put somebody at a higher risk of developing this. Are they doing things that might make them higher risk? Do they have poor dentition? So poor dental status can lead to it because it can seed the blood pretty easily. And we talked about how the steps in the process to develop infective endocarditis is not just as simple as having blood or having bacteria in the bloodstream. There needs to be some sort of endocardial surface injury first that then leads to a healing reaction, and you get like that thrombus formation. That creates an environment that if you have bacteria in the blood, so bacteremia, that bacteria will then invade that thrombus formation, and it will then make this already complex kind of structure even more complex because the bacteria are going to interact with it, break down products and those types of things, and make this a very complex kind of structure known as a vegetation. And that vegetation then serves to protect the bacteria from like antibiotics that you might give to treat it, making it exceedingly difficult to actually treat these folks. Then we talked about how you have the Dukes criteria, or modified Dukes criteria. Don't memorize what goes into it, but just recall that to be able to diagnose somebody with infective endocarditis, you need either 2 major criteria, or 1 major, 3 minor, or 5 minor criteria in order to diagnose this as a definite infective endocarditis. For possible, you kind of just go down 1 step, so 1 major and 1 minor, or you have 3 minors. And then when you're trying to diagnose this, it's important for you to take a good history in order to determine risk factors for doing this. But on exam, one of the more common things that you're going to see is a new regurgitation murmur affecting that valve with a fever. If you have those 2 symptoms, then you should be very concerned for infective endocarditis, because when you look at the frequency of these symptoms presenting in your patients, fever and new heart murmur are the most common symptoms that you'll see with patients. And then you can see like the normal things that we associate with infective endocarditis actually are not that common. So you can't sit there and rely on the Osler nodes or the Janeway lesions in order to diagnose this patient with infective endocarditis. Recall also that the initial presenting symptoms of infective endocarditis may actually be a complication of the infection, which could include they're coming in with like a stroke because parts of that vegetation are chipping off and getting sent downstream. It could be septic emboli going to other things outside of the central nervous system. It could be a metastatic kind of infection, so it's going to like the bones, and they start having bone being eaten away because that infection is now seeded into that structure, similar to the case that I presented from my residency. How do we do this? How do we diagnose this? First thing you're going to do is get blood cultures, because you want to know what you're dealing with and what it's sensitive to. Ideally, you want to get this before you get antibiotics on board, so you don't get a false result. Then you're going to get an echo, and you're going to look for that evidence of that vegetation. Typically, we do a transthoracic echo first because it's less invasive. But if that transthoracic echo does not detect that vegetation and you are suspicious for infective endocarditis, go ahead and do the transesophageal echo, because it is a lot more sensitive of a test to detect that vegetation. Then we talked about how some additional symptoms are like your vascular phenomenon or your immunologic phenomenon. And we talked about how one example of a vascular phenomenon is Janeway lesions, which are just like these little erythematous spots, and these are painless. We talked about splinter hemorrhages being visible under the fingernails, toenails. If you have somebody who has a right-sided infective endocarditis, it may cause a septic pulmonary emboli. Then we talked about how now you're in with like immunologic phenomenon. If it's going up to the retinas, it's called a Roth spot, where you get kind of central clearing with like a erythematous reaction around it. You get Osler nodes, which these are differentiated from Janeway lesions by being painful. And then we talk about some other studies that you can get, which may or may not be positive, depending on if it's affecting other structures. And then when we go to start treatment for this, remember it's going to take 1 to 2 days to actually get any results on that culture that you got. So you got to start antibiotics based on what is the most likely organism that's affecting that individual. So if they have somebody who is a drug user, typically you're going to start on treatment for MRSA, but understand that it could be a number of other really bad bugs, including Pseudomonas in Candida. So maybe while we are waiting for results, maybe we should have them on antibiotics to cover those things as well. If you have an older patient who has their own heart valves, be thinking of like strep viridans as your potential etiology. So targeting the treatment to target strep viridans would be great. If somebody has a prosthetic valve, then it could be something like staph epidermidis. So go ahead and start treatment for that. If your culture comes back with strep catalyticus, then this could actually be an indication of a colon cancer, and they probably need to get a colonoscopy as soon as possible. But the treatment's going to entail, these folks are going to be very sick. Let's admit them to the hospital, particularly like an intensive care unit or cardiac care unit. You're going to get blood cultures. You're going to start them on empiric antibiotics that are targeted against the most likely organism, and then you're going to get help. So you're going to consult all of these specialties to help you manage this patient. Even if they don't necessarily meet the criteria for surgery, it's always great to have that surgeon on board in case you need to go in and do a surgery to get rid of that vegetation. Then we also talk about how the antibiotic course, where this is not your simple 1 week to 10 days like we do for most antibiotics. This is something that's going to be on a very prolonged course because that bacteria is hiding away in that vegetation, and it's going to make it very difficult to eradicate all of that bacteria. So you're going to have them on a very long, prolonged course of antibiotics. And then there's all these complications that could develop. Think of the case that I presented of different structures and stuff that were impacted by these emboli getting thrown off. There's a high risk of relapse. Usually it's going to occur within 2 months of it. But also recall that there is a high mortality rate, even if they're in the hospital, for this condition because of how complicated and complex this case is to diagnose and manage. And then we finished talking about infective endocarditis by talking about prophylactic antibiotic use, where there's certain people who are going to be at higher risk of having infective endocarditis or developing infective endocarditis. So if they're going to undergo a high-risk procedure, such as dental type of procedures, then maybe they need to be on a prophylactic antibiotic. So do they have mechanical or foreign bodies inside the heart? Have they had this before? If you've had endocarditis once, you're at high risk of having it again. Do they have some kind of anatomical variation, like congenital heart disease there, that can put them at a high risk of developing infective endocarditis? And when it comes to actually giving them treatment and giving that prophylaxis, most folks will do well with just giving 2 grams of amoxicillin. But if they are penicillin allergic, then there is things like cephalexin or Keflex, and your macrolides can also be used to provide that prophylaxis. Then we went on, we started talking about congenital heart disease, and we talked about how in the fetal circulation, kind of the 2 main things that are different is the oxygenation instead of occurring in the lungs, it occurs at the level of the placenta. And then we talked about how the right side of the heart actually carries oxygenated blood, not just the left side. And we talked about how you have two main structures that are developed in the fetal circulation in order to get that oxygenated blood from the right side to the left side in a more efficient manner without having to go through the lungs and wasting work, wasting effort. And one of those structures was the foramen-ovale, which is a one-way flapper valve that only allows blood to go from the right to the left when the pressure on the right side is higher than it is on the left atria. And then we talked about how you have the ductus arteriosus, which is a connection from the pulmonary artery to the aorta, and that just serves as a diversion for any blood that does happen to get up to the pulmonary artery. It can then divert it down into the aorta and bypass the lungs. Then we talked about how congenital heart disease is the most common congenital diseases that you're going to encounter. This especially is true in your premature infants. And the reason that this is something that is required for us to teach in PA school is most of these could be diagnosed in your primary care clinics for routine follow-ups and not necessarily diagnosed in the nursery right after birth. And we talked about how the reason this comes up, or this could be, this condition can develop, is it could be just the process of the development of the heart in utero. Just something went wrong that led to the error in the development of that. It could be a genetic thing, so everybody in the family has this condition, so baby's going to have it. It could be a spontaneous mutation when the gamete cells are being produced. There was just a spontaneous mutation that occurred, and that led to this condition. It could be environmental exposure, so while the mother is pregnant with the baby, they got exposed to something that has a teratogenic kind of effect, and it led to the development of this condition. Things like fetal alcohol syndrome or maternal rubella can lead to this. And then the final grouping of things are, what is the health status of the mother and how that could impact the normal development of the baby. So somebody with poorly controlled diabetes, how is that going to impact the development of the baby? Somebody with hypothyroidism or hyperthyroidism, how is that going to impact the development of the baby? Yeah.
Gestational diabetes too?
Yes. Usually though, the one caveat of gestational diabetes is that normally occurs later on when many of the organs have already formed. So it may not have like an organogenesis problem. It's more likely they're going to have like a growth problem. But if they have like type 1 or type 2 diabetes before pregnancy, then that can affect organogenesis. So. One of the things we did talk about was the formation of like the atrial septum, on how you can see in the development early on, the atrium septum is developed in a way where you get that pathway for blood to get from the right to the left for in utero purposes, but then it's also arranged for after birth where you don't have that persistent right to left translocation or left to right. And that's with the use of our development of the septums and the ostiums. So you initially have the ostium primum, which is the early stages of it, where it's just there's no connection whatsoever between the right and the left, or sorry, there's no separation between the right and the left. You start getting the septum primum, the first septum to develop, it grows down, but to be able to allow blood to get from right to left, it produces this little hole or this ostium called the ostium secundum, the second ostium. But you don't want that permanently opened, so then the septum secundum grows in and kind of overlaps that and creates that one-way valve, flapper valve, in order to provide that foramen ovale so that blood can get from right to left in utero. But then after birth, that will get sealed shut because you have a higher pressure on the left side compared to the right, and that will keep that closed so you don't have that right to left shunting occurring still. However, in the process of that development, let's say that those ostiums grow too large, or that septum doesn't grow enough, and now you have this permanent loss of tissue so that you have this bridging between the atrium occurring in the wall, and that leads to atrial septal defect. And the problem with this is, in a normal baby right after birth, you're going to have a higher pressure on the left side, so that's going to cause blood to flow over to the right atrium. So now that deoxygenated blood is going to occur in the right atrium. It's not going to lead to cyanosis, but it's going to lead to higher volumes, higher pressures on the right side that the right side of the heart shouldn't normally experience. And that can lead to pathology. Most small ASDs are not going to cause symptoms. However, if they are larger or it's been going on for decades, then things can develop and they may become symptomatic from it. If you have a large ASD, these little babies are going to present almost immediately with symptoms that are affecting like lungs, but also their feeding and other kinds of things mimicking like a right-sided heart failure. If they have moderate to large ASDs and they're not diagnosed, and those, that can then lead to chronic kind of changes, which then can have long-term consequences. On physical exam, what are you going to hear? So the fixed split S2 is kind of the common kind of descriptor that you're going to hear for this. So if you see fixed split S2, be thinking atrial septal defect. There may be some other flow murmurs that develop because of all that extra blood being on the right side. It's going to go across those normal valves and create kind of like a turbulent flow, so you actually could hear that on auscultation. Your EKG may be normal, but you may notice some, especially if this is chronic, you may see some changes on the EKG suggest hypertrophy or atrial enlargement because that right side is having to deal with higher pressures, higher volumes. It's going to compensate for that. Echo is going to be your test of choice because you're going to be able to see it. You're going to be able to measure that flow between the left and the right. So echo is your test of choice for this condition. Fortunately, most ASDs, especially if they're less than 6 millimeters, are going to heal spontaneously without us having to do anything, so we're just going to watch them closely. If they are larger than 8 millimeters, though, however, those tend to not heal on their own, and those folks tend to have to go and get surgery to fix that. And there's a couple of ways that we can do it that we talked about, but just know surgery might be an option to fix that. Then we talked about the patent foramen ovale. So we talked about foramen ovale being a normal structure in utero. There's a purpose to it. However, it may cause problems if that flapper valve does not scar down and it remains open, freely movable. It may lead to problems down the road. So if a patient were to develop a condition that increased that pressure on the right atria compared to the left atria, it may cause that flapper valve to open, and now you can get right to left shunting of blood. This is especially seen in folks who are low risk for strokes, who just happen to have a stroke, where they had a clot that formed, and instead of it getting to the lungs and getting filtered out there, it passed through that patent foramen ovale and got into the left side of the heart, and then got thrown up to the brain and causing the stroke. So if you have a low risk person who has a stroke, be thinking of this condition. And the way that we can diagnose this is by doing an echocardiogram and doing a bubble study component to it. So basically what's going to happen is I'm going to do a normal echo, and typically I'm not going to see anything abnormal on the normal echo. Then I'm going to do this bubble study where I'm going to inject saline rapidly. That's going to increase that pressure on the right. I'm going to see those bubbles, and then I'm going to see those bubbles go from the right atrium and into the left atrium. That is an abnormal finding. Then we move down and talk about ventricular septal defects. We talk about how this is the most common congenital heart disease that you're going to see in your patients. Fortunately, the vast majority of patients are going to have this heal on their own without us having to do anything about it. And basically what happens with this is you're going to have all this blood going from the left, so oxygenated blood going from the left ventricle and into the right ventricle, mixing with that deoxygenated blood, and then that gets sent up to the lungs. And it's already oxygenated, so it's not necessarily going to get re-oxygenated. So you're wasting effort, wasting work, and wasting function of the heart. Over decades, the problem with this is it can then lead to a reverse of the shunt where instead of you now having this left to right shunt, that pressure on the right side, because of having to compensate for this condition, you may have that shunt reverse, and now you get a right to left shunt, and now you're mixing deoxygenated blood with oxygenated blood on the left side, and now you're having hypoxic blood going out into the arterial system, and that's Eisenmeinger's syndrome. What are you going to see on exam? The most common auscultation finding, or auscultatory finding, is going to be this harsh holosystolic murmur, often heard at the left sternal border. Echo is going to be your test of choice for this, because you can see that defect, and you can actually measure the amount of flow going across it. And then we talked about how most small VSDs are going to heal on their own without us having to do anything. We just monitor it closely. If it's large, then we may have to do a surgery to fix it. There are some things that we can do temporarily to kind of get them to surgery to help with this, but ultimately they tend to need surgery to fix it. And then recall our antibiotic prophylaxis for infective endocarditis. And then this was just Eisenmeinger's syndrome. So this was that compensatory change that occurs over a long-standing history of this shunt, where the right side is having to see higher pressures, higher volume than normal. The body is going to compensate for that. And one of those things is you're going to get pulmonary hypertension. And that pulmonary hypertension may then cause that pressure on the right ventricle to exceed that on the left. And now you're getting a reversal of that shunt. So now you're getting that right to left shunt. And now you're getting that deoxygenated hypoxic blood getting sent to the arterial system instead of to the lungs like it should. And the best way to treat this condition with Eisenmeinger's is actually just to prevent it in the first place, correct that congenital defect before it has time to cause compensatory changes. Then we went on, we talked about patent ductus arteriosus, where you don't have that normal obliteration of the ductus arteriosus, because this is a normal pathway that we need in utero. But after birth, we don't need it anymore. Typically what causes this ductus arteriosus to go away is you get that oxygen tension, which then triggers a prostaglandin decrease, and then it closes this. But in conditions where that prostaglandin level stays high, it keeps this open. And what happens is, instead of the normal in utero, where I'm getting pulmonary artery to aorta, after birth, what happens is you have blood going down the aorta, and then it goes through that patent ductus arteriosus and into the pulmonary artery. So now the pulmonary artery is seeing higher pressure, higher volumes than it should normally. And then that can lead to pressures increasing in the pulmonary circulation, which over time can lead to an Eisenmeinger's syndrome, where now you're getting a reversal of that flow, where now you have deoxygenated blood leaving the pulmonary artery and going into the aorta, which then gets sent downstream to the lower body, lower extremities. And what you can see on exam with somebody who has Eisenmeinger's syndrome from a patent ductus arteriosus is the upper body, the upper extremities are going to be normal appearing, but the lower body, lower extremities are going to be cyanotic. Because that mixing occurs after the aortic arch and not in the heart itself. Patent ductus arteriosus, depending on the size, they could be asymptomatic. If they are large, then you might see some feeding or breathing issues. The pathognomonic kind of description that you're going to hear for a PDA is this continuous machine-like murmur that is best heard at the left upper sternal border. Echo is going to be your test of choice to be able to diagnose this. And then the treatment for it's going to kind of depend. If you have a premature baby, well, let's give them an NSAID to get rid of that prostaglandin. So indomethacin and ibuprofen are great at helping reduce that prostaglandin levels, so you naturally have a closure of the patent ductus arteriosus. If it's an older infant that's born with this, or you're diagnosing this as like an adolescent or an adult, then we may need to go in and do like an ablation, like a coil ablation, or we may have to do an open thoracic cavity surgery where we tie that across and close that connection. Then we moved on, we talked about coarctation of the aorta. And we talked about how this is associated with Turner syndrome, so that 45XO condition. And we talked about how this can lead to normal blood flow to the upper body, upper extremities. However, the blood flow going to the lower body, lower extremities can be impacted to the point where there could be minimal to no blood going down there. For mild coarctation, they may be asymptomatic. They may just have like headaches just from that extra blood flow. If they have more severe, then they may have cyanosis affecting the lower body with that. The body does try to develop some collateral circulation, so it tries to find a way around that. So you may see some other conditions develop, but typically what you're going to see on physical exam is a systemic hypertension that's asymmetric, where the blood pressure is higher in the upper extremities, and then when you compare the blood pressure to the lower extremities, there's at least a 15 to 20 millimeters of mercury difference in the systolic pressure. Other things you're going to have on auscultation is a infrascapular murmur. And basically what you're hearing is that turbulent blood flow trying to get through that narrowed lumen. Echo is going to be your test of choice, but chest x-ray you may start to see like rib notching just from that collateral circulation. Treatments could be a number of different things. We may just go in and remove it. We may go and put a balloon in there trying to open up that lumen again. But there's a couple of different ways that we could fix that. And then remember your infective endocarditis treatments. These folks will undergo brain imaging and stuff because there's a risk of them developing intracranial aneurysms, which could put their life at risk in the future. And then we moved on and we started talking about cyanotic congenital heart lesions. We talked first about tetralogy of Fallot, which is made up of 4 primary abnormalities that are all come down to this anterior encephalad displacement of the infundibulum of that ventricular wall. And basically, with that movement or that distortion of the normal anatomy, what ends up happening is they have a ventricular septal defect because you didn't have the superior and the inferior part come down and meet each other to give you that clear distinction of left and right. You're going to have a right ventricular outflow obstruction, kind of mimicking like a pulmonary stenosis. You're going to have a right ventricular hypertrophy because now you have all that extra pressure and all that extra volume that the heart's having to work with. So it's going to compensate for that to try to generate a larger, more powerful squeeze. So it's going to get that right ventricular hypertrophy. And then you also are going to have an overriding aorta. When the right ventricle squeezes, the path of least resistance is for that deoxygenated blood to leave and go up through the aorta instead of through the pulmonic artery. Now, if it has an atrial septal defect, so in like a description of having like a having the, not continuous machinery, what's the aortic, fixed split S2, sorry. Fixed split S2, if you're seeing that, it could indicate that there also is a ASD present, and that would be indicative of a pentology of Fallot, so 5 things wrong of Fallot. And tetralogy, from a genetic standpoint, is associated with DeGeorge syndrome, which is that microdeletion in chromosome 22. So if you see somebody with DeGeorge, be concerned that they could also have tetralogy of Fallot. And then we talked about why the pathophysiology of this condition, why we see what we do. We talk about TET spells, which is anything that increases the like the preload, so things like irritability, cyanosis, feeding. It tends to cause the cyanosis to get worse. So you try to minimize the baby getting upset, but you can't really, it's difficult to manage. You have to feed them. It's hard to comfort them when they're crying. So what are you going to see on physical exam other than like the cyanosis? You may get a mild systolic ejection murmur that's mimicking like a pulmonic stenosis. You may hear the VSD murmur, so you may have that holosystolic murmur from that. Ancillary studies could show you some things, but the echocardiogram is going to be your test of choice because it's going to show you that abnormality there. And then we talk about how treatment, mainly is going to be surgery to fix that, but one of the things they can do to temporize it is by doing like a knee chest or doing a squat, which this works by increasing the afterload so that you're trying to encourage more of that blood going through the pulmonic valve and into the pulmonary artery in order to become oxygenated and just increase the overall oxygen content of the blood. But ultimately, they're going to need surgery to fix it. And they tend to do pretty well with the surgery, and the prognosis is actually pretty good, where 90% of folks will survive at 25 years. Then the last cyanotic heart lesion that we talked about was transposition of the great arteries. We talked about how now the aorta is coming off of the right ventricle and the pulmonary artery is coming off of the left ventricle. And this creates two distinct circuits that do not interact with each other. And this is universally fatal if you don't catch it quick enough because you have no oxygenation that's occurring. This works in utero, but as soon as they're born, especially as that ductus arteriosus starts to close, they will become cyanotic pretty early on and will start to struggle pretty quickly. Your chest x-ray may show this egg on a string kind of appearance, so that's the normal descriptor of it. But echocardiogram is going to be your test of choice. And the way that we fix this is I can give them a prostaglandin E1 infusion, such as like alloprostadil, in order to keep that ductus arteriosus open until I can get them to a center that can do this surgery for them. Where then I'm going to do, mainly what we do is an arterial switch where we just disconnect the pulmonic artery and disconnect the aorta and just swap it. But there was an alternative to that surgery, which you can see here is pretty complicated, but they're going to need a surgery to fix this. Then we moved on and started talking about our last one, which was pericarditis. We talked about acute pericarditis. The most common cause of this is idiopathic or viral. We talked about how there's lots of things, both infectious that can cause this, but also non-infectious things, such as they just had a heart attack and now they have this inflammatory reaction that's going to cause inflammation of the pericardium. And we talked about how basically whatever the cause of this condition is there, it causes that local vasodilation, which causes that vascular permeability to increase, and then you start getting stuff migrating where it normally shouldn't go, and that triggers this inflammatory type of response, and then leads to this condition. And what you might see is a little bit of fluid, like a serous kind of fluid that you see here. It could lead to like a serofibrinous deposit, so you get fibrin being deposited in this area, and that can cause like that friction rub that we often hear. If it's suppurative, so you're having like this abscess that's occurring around the heart, be thinking of a bacteria that's causing this, and this version carries a high mortality risk for it. And then if you see a hemorrhagic fluid, be thinking of tuberculosis or cancer as the causative agent for this version of pericarditis. Then we talked about how these folks are going to present with chest pain, but the chest pain is different from other causes because it is a positional chest pain. So they sit up or lean forward, it makes it better. They lay back, cough, take a deep breath in, it makes it worse. And then we talked about how you can get that pericardial friction rub, and that can be heard on auscultation. Things that might make somebody high risk for this and just may not go away on its own or may need some other interventions is if they have like a high fever and mucocytosis, it could be a bacterial cause. If they're having a large pericardial effusion, then that could lead to additional procedures that need to be done in order to treat it. If they're immunocompromised, it's going to be more difficult to manage these patients. So be a lookout for red flags that this may not get better on its own. For EKG, you're going to have the typical EKG findings of acute pericarditis. So you're going to have diffuse ST elevations, you're going to have PR segment depressions, you're going to have this concave upsloping of the ST segment, so that those ST segments that are elevated are going to have this concave kind of appearance to them. And then spottic sign can also be seen. And 90% of patients who have pericarditis are going to be having an abnormal EKG with these findings. Echo, you're going to want to get an echo of these patients because you're looking for any kind of complications associated with it. So look for, you're using the echo to look for complications. If they don't have evidence of like an effusion initially, then you're going to want to repeat this in 1 to 2 weeks because you want to make sure that they haven't developed a complication. And then the treatment for this is going to be colchicine plus an NSAID. Your NSAID options are aspirin, ibuprofen, naproxen, and indomethacin. And you're going to want to do this for at least 2 weeks because you're going to want to, this will, one, make them more comfortable, treat the pain, but it also will decrease the development of complications like scarring and stuff like that, and leading to like a constrictive pericarditis. The one caveat to treatment is if this is in the setting of a heart attack, don't use ibuprofen, don't do indomethacin, don't use steroids. You're going to be using aspirin instead. Okay, so if pericarditis is in the setting of a heart attack, aspirin and colchicine are your treatment options. And then you're going to have a return to play or return to activity. So avoid any kind of strenuous activity for at least 4 weeks after diagnosis of pericarditis. Then we talk about infusion, where infusion is basically that fluid amount exceeds that of the normal amount. So like 51 milliliters up is an infusion. And a lot of the similar things that can cause a pericarditis can also cause an effusion. The one difference is malignancy now is the most common cause of a pericardial effusion. The presentation is going to be dependent on how bad it is. It may be completely asymptomatic, but you may start to get compression of other organs. So if it's pressing on the lungs, they may get shortness of breath. If it's pressing on the esophagus, they may have difficulty with swallowing. If it's hitting the nerve, the recurrent laryngeal nerve, they may get hoarseness and such. So it may be the symptoms that prompt you to think of pericardial effusion actually are symptoms of other structures being affected by this. Ewart sign is kind of one of the key findings for this that you may see, and that is just a dullness to percussion over the posterior left lung. EKG, you could see electrical alternations, especially if this is a large effusion, but your echocardiogram is going to be your test of choice because you can actually see how much volume is in that effusion and also assess for any kind of functional limitations from that. And then you're just going to treat the underlying cause for it. Okay. That brings me to 11:50. We got through most of this. Cardiac tamponade is just basically an excessive amount that affects the actual function of the heart. You're going to drain it with needles to restore function. Constrictive pericarditis is kind of a chronic thing, scar tissue forming from like pericardial disease. And the way you treat that is you have to remove the pericardium entirely. And then myocarditis was the last thing that we talked about, and that's just inflammation of the myocardium itself. That has a wide presentation variability, so it could be asymptomatic to sudden cardiac death. And basically, you just need to support them and treat whatever the potential cause is for that myocarditis. So it's kind of the key things. Questions? We have office hours, so just let me know if you want to meet up. If you have questions, the lab may answer some of those questions. We're going to get a lot of practice with this. And then I'm also available by Canvas. Just send me an email. I'll be checking my Canvas email regularly, even over the weekend, so I can answer questions. So I'll see you all Friday for the lab.